when we do lose weight, we do see the metabolism drop, and that's across the board. And if you look at the Biggest Loser data, they had that big study that came out a couple of years ago. I mean, it's pretty impressive. So here they took 14 of the 16 Biggest Losers from season one. They lost over 100 pounds initially. They regained about 80% of it over 6 years. They're still down like 30 pounds from where they started, which is good, but they were down 130 at one point on average. And even though they had regained almost 100 pounds over those 6 years, their metabolism was still at or below where it was when they finished the Biggest Losers. Wow. So even going out 6 years, their metabolism was still dropped. Now, is that metabolism going to come back to the baseline once they get back to like their set point, their starting weight? We don't know. We don't have that data yet. But I don't think the more times you attempt that you kind of broke yourself. It's just everyone that loses weight is going to have a slowdown in metabolism. It goes back to what we talked about at the beginning, that metabolic adaptation, that physiology that we have, that our body is really good at defending weight.
Welcome to the Exercise is Health podcast, where we're talking about exercise, health, and the interconnectedness of the two. We are your hosts, Charlie
and Julie,
and we will be coming to you every single week from our studio, Muscle Activation Schaumburg. Hey, welcome back, everybody, to the Exercise is Health podcast. We are your hosts, Charlie
and Julie,
and we are coming to you from our studio, Muscle Activation Schaumburg in Schaumburg, Illinois. Now, at Muscle Activation Schaumburg, we believe your health is your most valuable asset. Your health is one of the biggest influencers of the quality and quantity of time that you have. And while there are many aspects of health, our expertise is exercise. Exercise has been proven time and again to not only improve your health, but also increase your longevity and improve your quality of life. But we know that exercise is not the only piece of the puzzle, and that is why we are bringing you a phenomenal guest today, none other than Dr. Anthony Auriemma. Dr. Anthony Auriemma is a medical weight management specialist with AMITA Health. He takes a multidisciplinary approach to helping patients lose weight, including working with others who specialize in exercise, nutrition, and psychology. Dr. Auriemma, thank you so much for joining us and welcome to our show.
Well, thank you for having me here today.
Absolutely. So expand on your bio a little bit for us. Tell us more about kind of what you're doing now and how you got into medicine and weight loss specifically.
Sure. So I actually started my career in family medicine. I was a resident at Hinsdale Hospital here in the Chicago area and training to be a family medicine doctor. And during my third year of residency, I started moonlighting in the evenings in a weight loss center. And what had happened is I started seeing some of my same patients I saw during the day in the residency clinic, I would see in the evening in the weight loss clinic. And instead of adding more and more medications for high blood pressure and diabetes and all their other problems, a lot of times in the weight loss center, we were taking away those medications. And I realized that many of the chronic diseases I was treating as a family doctor, I could help, put into remission or greatly improve by concentrating on, dietary intervention, improving nutrition, lifestyle, exercise.
Oh, that's awesome. So when did you make that shift then from family practice into weight loss management?
So right after residency, I took a job full-time doing family medicine, and one night a week I opened up my own weight loss center.
Wow, very cool. Was that in the Chicago area as well?
That was in Oak Brook, and I opened up on Monday nights. I was only open up for 3 hours. It was a dietitian, myself, and a medical assistant.
Very cool.
Over the years, that grew into multiple locations. And then about 7 years ago, I switched over full-time to just obesity medicine is what we call it now.
Oh, very interesting.
So that's all I do is work with patients to help them lose weight.
Very cool. So describe like your typical patient. So I'm guessing obviously it's somebody that needs to lose weight, but are they younger? Are they older? Are they kind of have struggled with weight loss in the past? Is this their first attempt at weight loss? What's the general story of somebody that comes in?
Well, the average patient has, basically tried multiple programs, lost weight multiple times, only regained. But we see patients on the whole spectrum, anywhere from 12 years of age all the way up to my oldest patient is 90 years old.
Wow.
So we see the whole range. But the average patient that comes in is probably in their 40s and 50s. They've done all the traditional weight loss type programs. They hired the trainer for 3 months and did some over-the-counter supplement or something Dr. Oz was selling that was going to fix it. And then finally they're referred to us either by their physician or they run into someone that was a successful patient of ours, and they come in for help.
Very cool. And so how long are they typically with you?
So we ask our patients to make a 2-year commitment.
Oh, awesome.
So we are a 2-year program.
I love that.
And actually, after they come in and they say, okay, I'm all in for 2 years, we tell them, all right, we lied to you.
Okay.
Because this is not a 2-year disease. This is a chronic disease.
Yeah.
And that's one of the difficulties that we've had as a society in treating excess weight or obesity is we've done these 30-day fixes, these 12-week programs, a 6-month boot camp, but really this is a chronic disease that patients have to manage lifelong.
Expand on that, because that's the first time I've heard it phrased as such, but it makes perfect sense, because that would be a great explanation as to why so many people do these kind of yo-yo weight loss plans and why people struggle to lose weight for the long term is because it's not being seen as a chronic illness. It's being seen as a number on a scale. So can you expand on that idea as far as what do you mean by it's a chronic disease?
Yeah, so it's really changed. Our understanding of this process of weight gain and weight regulation has really changed over the last decade. All my training in medical school and even in residency, what most of us probably remember, it's all about calories in, calories out. Right. It's a simple, addition, subtraction equation. And I wish it was that easy. If it was that easy, we probably wouldn't be having the epidemic that we have today. Currently, 42% of the U.S. adult population has obesity.
Wow.
42%. And what we've found out over the last 10 years plus is through a number of studies and understanding our metabolism better and how things work is that there's something called metabolic adaptation. That once we gain weight, the body defends that weight.
Okay.
So once you gain, say, 50 pounds, it's kind of the idea of set point. Your body kind of sets in and wants to maintain that. So when you attempt to lose weight, we see hormonal changes from gut hormones that promote weight regain and promote hunger.
Wow.
We see differences in metabolism. So when you lose that weight, your metabolism goes down disproportionate to your weight loss.
Interesting.
So if you were 200 your whole life and you go up to 250, then you go back down to 200, when you go back down, after gaining that weight, your metabolism is actually lower than it was when you were originally 200 pounds.
Interesting.
So the body likes to fight to defend that weight.
Interesting.
And that's why most patients have had the experience that they've lost weight. Almost every one of my patients has lost weight.
Sure.
It's really maintenance of weight that's the most difficult because they're fighting this physiology of their body.
Well, that insight right there would be such a great explanation as to why it's so difficult for people to keep weight off. It's one thing, like you said, to lose the weight, but then to be able to keep that weight off, you're talking about a total shift in so many different systems of the body. This is really complex. You're right. It's not just calories in, calories out. It's much more in depth than that.
Correct.
Very, very interesting.
Okay. So what is the definition of obesity versus just being overweight or just having extra weight to lose? And how does this disease state process begin? Because it seems like it's a lot more than just you got weight to lose.
Yeah, that's a great question. So the World Health Organization defines obesity as accumulation of excess body fat that causes disease or impairment. It's not just a BMI number. Body mass index, which is a height and weight calculation, correlates with the disease of obesity, but technically does not define it. And I think some people get that mistaken. And also the BMI is, normal BMI is different for someone of European descent versus someone who's from Asia or India.
Interesting.
So, we typically consider, Europeans or most of the rest of the world to be obese when they have a BMI over 30 or to have obesity. And typically for Asia and India, it starts at a BMI of 25.
Oh, interesting.
So the BMI is a marker, but we always have to look at the individual. As you know, if you look like you exercise a lot and have muscle mass and you've been around a lot of athlete type people, they can have elevated BMIs, but they don't have excess weight or excess body fat. So it's the accumulation of excess body fat. And how do we get here? That's the $1 million question.
Okay.
That's the $1 million question. So we've seen a over tripling of the rate of obesity since 1980.
Wow.
So in the last 40 years, so since I've been around, we've tripled the rate of obesity, down from about 13% in 1980. Our latest data from 2017 is 42% of the population has the disease of obesity, and another 30% have the disease of being overweight. And overweight is just the beginning of obesity.
Sure.
It's just a spectrum.
Sure.
Because we see, even with mild weight gain, 5-10 pounds, even a normal BMI, or what you consider a normal weight for a patient, risk starts to go up.
Really?
So risks like diabetes and hypertension and even heart disease. So it doesn't take a lot of weight to start seeing risk increase.
Interesting.
And so exactly how did we get here? I go to major conferences every year with the experts from around the world, and there's arguments about this all the time. We don't know exactly why. I mean, some of the big big things that we look at is definitely the introduction of way more refined carbohydrates, easily digestible carbohydrates in our diet. Part of that was probably our own fault, the medical community, or the USDA and the low fat kick in the 1980s started, late 70s, 80s. So we refined food, pulled the fat out of it, and then added sugar to it to make it taste better.
Interesting. Okay.
We sleep less, we smoke less. I'm not advocating smoking, but when patients quit smoking, they tend to gain weight. We know we're having our society has changed in terms of both spouses and the heads of the household working less time together as a family meal time. Family meal time for my patients is typically a drive-through in the minivan. Because society has changed. More people are working, kids are involved in more activities, so we don't have that home cooked meal like we used to.
Right.
So technology, right? I spend most of my day in front of a computer now.
Sure.
So like a lot of people. So I think it's a combination of those things.
Very interesting.
When you said the definition, you said this, I'm gonna mess it up, but I'll try it. It's a weight gain, but that leads to disease and other changes that are negative. It sounded like something like that. So when someone wants to become healthier, is just losing weight any way possible going to actually improve how they're doing because the weight is what's causing all these issues? And are there negative side effects that you commonly see, like maybe malnutrition or something like that, just from losing weight in any way possible? But they would see some kind of improvement maybe if the weight is what's causing the issues, right?
So that's an excellent question. So we got to remember weight. Weight is just a number on the scale. What we want to look at is the excess fat.
Okay.
So a lot of patients will do well and lose weight doing a cabbage soup diet or some type of crash diet. Their scale will look great. They'll lose numbers on there. They may feel better. But what also happens is they'll lose lean body mass and muscle. And so even though the scale may look better, it's not better for them. So losing weight at all costs, no. You definitely have to do something that's evidence-based or has some legitimate, scientific background behind how to do it. So I wouldn't advocate any, fad things like that. And the greater question is, does the disease cause the weight gain, or does the weight gain cause a disease? The chicken or the egg question. That's very interesting, because we used to always think that type 2 diabetes was the result of excess body weight. But way before we ever see type 2 diabetes, you see pre-diabetes. And before you see pre-diabetes, you see high insulin levels, sometimes decades before anyone gains weight or develops blood sugar issues. So is it really that metabolic process behind type 2 diabetes, the insulin resistance and high insulin levels, that lead to weight gain over time?
Sure.
And then it's only when you're so far along in the disease that you've gained all this weight that finally the sugars start going up. And it's really the type 2 diabetes or the metabolic disturbance that caused the weight gain. So that's a great question.
Very interesting.
And there's unclear consensus out there in the medical community. But I definitely feel that the disease of hyperinsulinemia, which is a step before prediabetes and type 2 diabetes, causes weight gain. And that most of my patients that develop type 2 diabetes related to the weight, it's that diabetic process that caused their weight gain.
Okay.
So the chicken or the egg.
Sure.
Right, yeah. And is there a certain amount of weight that someone has to be overweight to come see you or to work with you or a program like you guys do?
We work with patients at all stages of their weight loss journey or weight control. We have patients that are in the normal range, but they just want to improve their nutrition or improve muscle mass. And the problem with just stepping on the scale is the scale may say you're in the normal BMI range, but we have patients that have normal weight obesity. So you can say, how the heck do they have that,
What
right?
is that?
Yeah, there you go. Both you guys.
Is it like skinny fat?
Do I have that?
Yeah, it's like skinny fat. So, and we see this in a lot of postmenopausal women. They'll have a BMI that's 23, 24, which is considered normal, but their percent body fat will be 40 to 50% because they have very little lean body mass.
Okay.
So they are at risk for the same disease processes as someone who weighs substantially more, because it's that fat tissue creating those hormones that cause inflammation, and the fat tissue creates hormones like estrogen, which leads to things like breast cancer. And so it's all that going on.
Interesting. So are people opposed to this idea of like, look, we have to look at everything? Do they want just, hey, give me what to eat and, how much to move, and then I'm good from there? Or what has been your experience with the reception that the patients have been giving you as far as this idea is concerned?
mean, the nice thing that we were able to do in our office, which is AMITA Weight Loss Solutions, is I have a team of individuals, dietitians, exercise physiologists, a licensed clinical social worker, myself as a medical provider. So we can kind of attack it, the disease from all angles. So if someone's eating because of stress, we have the behavior person or the counselor. If it's more education on diet, we can sit down with a dietitian. If it's some of the other chronic diseases or even the medications that physicians are using for other diseases that cause weight gain, then I can work with them to help modify those type of things.
Oh, very interesting.
And so there's a wide range of patients. We don't have like a one size fits all, but like you mentioned, some patients want just here, tell me what to do and I'll do it and I'll go execute. They're very good at following the plan. Other patients want to understand the why behind it and really want to get into more of understanding this metabolic adaptation and the gut hormones, and they're more cerebral and want to understand that, and they use that knowledge to be successful.
It's very interesting. Now, one thing that was really intriguing me about the bio and about your center is the aspect of psychology as it pertains to weight loss and the kind of the psychology of weight loss itself. And so you have a social worker on staff. What's the role that the social worker plays? You talked about stress eating, but does their role go beyond people who are just stress eating? Is there anything else?
Yeah, so we actually have our social workers do a couple of different things. So they're available for individual consultation like a counselor. She's a licensed clinical professional counselor and a licensed clinical social worker to do individual therapy if someone needs that. But the bigger role is in weekly classes. So our weekly classes are taught by an exercise physiologist.
Awesome.
We have a dietitian and then the social worker, which does the behavior component. And so they talk about stress eating, stress management, time management, avoiding food cues, like a lot of the other aspects of behavior that are important to maintain weight loss.
That's awesome. Now, discuss your role in more depth. You talked about, hey, if the patients are getting prescribed medications that may disrupt the weight loss process, you then, as a licensed doctor, have the ability to go in and help them with that or change that as necessary. So, what are some medications that you see that typically influence that, and kind of how do you work around that?
Yeah, so I mean, my role is, I think it's kind of threefold. One, I'm trying to look for any complications because of the disease process. So we know obesity is closely linked with, diabetes and heart issues and even osteoarthritis of the knees. So we want to evaluate patients to make sure we're not missing anything else. So that's one thing I do. The second thing I do is I want to optimize their medication and their other treatment. So the nice thing about being a family doctor background is we kind of have the big picture of the patient. So if they're on medications that can be causing, weight gain, we work to modify those. And the big ones that can do that are, a lot of the diabetes medications, specifically insulin. A lot of our psychiatric medications, like serotonin drugs, like Prozac, Paxil. Why many patients still need them, but sometimes those medications can cause weight gain.
Gotcha.
Definitely some of the antipsychotics that they use.
Sure.
Even some blood pressure medications like beta blockers can cause weight gain. And then my third role is, first of all, look for problems that are related to the disease, see if we can better manage the comorbid conditions so we don't make the weight worse.
Yeah.
And then thirdly, I can work with the patient and perhaps use pharmacotherapy, weight loss medications to help with weight loss.
So when someone comes in and they're going to do your program, do you feel like a lot of people get intimidated by the amount of aspects that are going on? Because I think a lot of people know that it's more than just diet because they've tried that, and it's more than just exercise because they've tried that. But to feel like, wow, I have all these things that I have to do, like diet and exercise and work on my mental state, is that overwhelming for a lot of people?
The vast majority of patients that end up in the exam room with me have kind of come to a point where they've tried all the quick fixes and they're ready to really jump in and make some major changes. And they get a lot of information about our program before they ever sit down with me that first day. So it's not a surprise. Now, once in a while, I have that patient that comes in and gets the evaluation. I make my recommendations. They're like, well, I like the way I eat. And like, I don't want to do that. Well, then I'm like, well, then I'm sorry, I can't help you. I mean, I don't have, I don't have a magic pill. But the vast majority of patients, by the time they're in our office, they're ready to be serious.
That's great.
And it's not only a change for them. This is the bigger thing I tell patients. It's a change for their whole family.
Yeah.
Their environment at home is probably going to have to change. So if they think that they're just going to make a separate meal for themselves every night and a separate meal for everyone else in the family, it's typically not going to work well. It's got to be kind of a a whole household change. But that's the good news. There is many of our patients, everyone in the house gets healthier because of the changes they're making.
That's definitely one thing that we have seen as a sticking point in the past with some of our clients is, they themselves are trying to make a change, but then getting everybody else on board. Not that their family or their spouse, significant other isn't supportive of them, but we're talking about kind of two completely different lifestyles. And so making sure that they are in an environment, like you're saying, that is going to help their new lifestyle grow and flourish. That's a really important thing. Do you do kind of family education in that regard? Like, can they bring their significant other, their family members in so everybody can learn? Or is it up to the patient to kind of relay the information?
So definitely when our patients sit down one-on-one with a dietitian to talk about, dietary planning, meal planning, changing the environment, they're always welcome to bring their spouse. And then I teach a science of obesity class typically once a month where they're, encouraged to bring in, whoever's at home with them.
Awesome.
So they can, so the other people can know kind of what the message is and kind of what we're trying to do.
Nice.
I love that. And I feel like I'm always so spoiled because I have Charlie, and I always tell my clients, I'm like, I have the worst self-control. You think I'm perfect because I'm a trainer, and I have the worst self-control. Here's the thing. You just can't buy it and bring it home. It just can't be in the house. And luckily, I live with Charlie, who's the most disciplined individual. And so I'm never tempted, but I understand how, people's lifestyles play a role, like what they go home to. Is there always refined sugars and carbohydrates and stuff they shouldn't be eating there? Or when they're at the office, are people constantly bringing in, celebration cookies? And, I can see how that can be such a challenge to get over, and such a, you have to be really determined to stick to your path if you're not in an environment like I luckily have, where I'm with Charlie at home, and here, it's a studio, so no one's bringing in cupcakes for me. But
Well, maybe you can rent Charlie out. He can go spend.
There we go.
I know. When I hang out with friends, I'm like, we're having pizza tonight. We're having ice cream. This is my once every 6
but
months.
Julie, you hit a very important point there. Our environment is much more powerful than willpower. I tell our patients, environment trumps willpower every day of the week. You could be the wimpiest person in the world, but if you don't have it around you, you have a good environment, you'll do great.
Yeah. Now, how long, this is going to be different for every single person, but, I understand it's going to be kind of a lifelong thing. You say, all right, patients are with you for 2 years, but really it's longer than that. It's not just the 2 years because there's ongoing management, I'm assuming, yes? So how frequently, once people graduate from the 2-year program, are they kind of checking in with your program?
So it's kind of customized to the individual. So I've had patients with me for, I started doing this 13 years ago, but I've had patients with me for 8 to 10 years. And I have some patients that check in for a weight check every other week for the last 10 years. I have some people I see every 3 to 6 months, depending on where we are in the process. Definitely initially out of the gates, we're much more frequent contact. We ask patients to come in weekly for weigh-ins and for classes. And then as time goes on, we can kind of modify it for that individual.
Okay.
Some people really thrive in the class structure and building that camaraderie with their peers and with the facilitators. Others don't really get as much benefit out of the classes. So it kind of depends on the individual.
Okay.
But we want to be a partner with the patient. So at any point in their journey, if things are moving in the wrong direction, if things are getting worse, they can always come in and ask for help, and there's no blame or shame.
Okay, awesome.
And that's the key. In the past, traditional treatment for obesity or weight is come in, do X, Y, Z, then you're fixed and it's over.
Right.
And that's not the case.
Sure.
Patients need lifelong support.
Well, just even the idea of like the gut microbiome changing and the hormones that are produced being more in line with creating weight gain. To be able to change that microbiome back to a state that's different than that, I have to imagine that that's a really long process. That's going to take a lot of input from a number of different sources, whether it be exercise, whether it be nutrition related, whether it be psychological. From my understanding, all those things can affect the gut microbiome. So it's really neat that your office looks at all those different things and helps patients with those different aspects. Do you find that people are really open to exploring all those different aspects?
I think it depends on the individual. I still have patients that feel that it's just their fault and they got to try harder because that's what they've been told for the last 30 years. If they just exercised more or ate less or had stronger willpower without, understanding this as a disease process. So I typically try to do a lecture every month for my patients called The Science of Obesity, where I ask patients to come in for a 45-minute lecture, and they can bring a spouse or loved one so they can better help understand that there is a physiology behind this. There is a disease process. This is not just this is not a character flaw. This is not just making poor choices. While obviously our behavior plays a role in it, that's not the major driver. The major driver is our physiology.
Yeah, definitely. So what are some of the biggest kind of misconceptions that you feel that you're having to overcome with patients as far as educating them on, and that are just kind of generally out there, whether it's perpetuated by the media or social media or anything like that, when it comes to weight loss?
Well, I think there's a couple of them. One particular one that I like to talk about is calories. So everyone, I was trained in the 90s and early 2000s that, calorie is a calorie. It's a unit of energy. It doesn't make a difference. It's all the same. And we really need to put that to bed. Different calories do different things to us. And anyone who's eaten 100 calories of broccoli versus 100 calories of peanut M&Ms understands that's two different experiences, right? That's not the same experience. And not just, in our mind and how it feels, but also in our gut and in the microbiota that has to digest this, and in the insulin release from the pancreas can be very different with those types of foods. So one thing is a calorie, so we have to change that. There's a big difference between different types of calories. And I think the other thing is the role of exercise. Exercise is very important. It's very important for weight maintenance. It's important for heart health, psychological well-being. It's great for stress management. When we're taking care of ourselves with exercise, we're more likely to take care of ourselves with our diet and everything else. But the idea that we can exercise away a bad diet, all the studies show that you can exercise to your heart's desire. If you're eating poorly, it's not gonna do it for you.
Yeah, very true.
Now, some of my patients take that message back to their doctor and they say, Dr. Auriemma said I don't have to exercise. So I think they hear what they want to hear in that regard. I'm not saying that. I'm saying we just want to put exercise in the proper perspective, because I see so many patients that come in, do great getting on an exercise program, getting the trainer, getting set up, and then the scale doesn't move and the exercise isn't working, so they quit exercising. So I just try to put in perspective, we're exercising for all the other benefits. The weight control is really about what we take in.
No, I'm 100% with you on that. Absolutely. And that's actually kind of why at our office, weight loss is not a specialty of ours. It's not that our clients don't lose weight with us, but we understand that weight loss is so multifactorial. And while exercising is important, like you're saying, for all the other health benefits, weight loss, that's not really its main thing. And one of our mentors said, look, if you are exercising simply for the calorie burn, it's like trying to work for minimum wage. It's impossible to keep up and you'll never get ahead. So when it comes to actually making your body efficient at burning calories and losing weight, yes, you can burn calories through exercise, absolutely. But that's not the thing that's actually going to help you lose weight. So, it's important for all the other health stuff, but no, I'm right there with you. I think that is really important for people to understand, very much so.
So, we're personal trainers, so we work with a lot with people that want to lose weight, and we're probably on the side of maybe they're trying their 3-month stint of their personal training weight loss experience. But I've read, and I don't know if you've seen this, the more times that people lose weight and then gain it back, and lose weight and gain it back, and then do it through exercise and then do it through diet, does that actually set them back metabolically or hormonally so that it's difficult to lose in the long run?
That is a great question. So I haven't seen any data out there that you kind of break yourself by trying and failing. I mean, someone who tries and has weight regain, they just have I think a higher degree of the disease or higher level of disease. When we do lose weight, we do see the metabolism drop, and that's across the board. And if you look at the Biggest Loser data, they had that big study that came out a couple of years ago, and it's pretty impressive. So here they took 14 of the 16 Biggest Losers from season 1. They lost over 100 pounds initially. They regained about 80% of it over 6 years. They're still down 30 pounds from where they started, which is good, but they were down 130 at one point on average. And even though they had regained almost 100 pounds over those 6 years, their metabolism was still at or below where it was when they finished The Biggest Loser.
Wow.
So even going out 6 years, your metabolism was still dropped. Now, is that metabolism going to come back to the baseline once they get back to like their set point, their starting weight? We don't know. We don't have that data yet. But I don't think the more times you attempt that you kind of broke yourself. It's just everyone that loses weight is going to have a slowdown in metabolism. It goes back to what we talked about at the beginning, that metabolic adaptation, that physiology that we have, that our body is really good at defending weight. And it probably served a purpose at one point where food wasn't so prevalent, but we don't have famines, at least not here in the United States.
Absolutely.
And when you're talking about metabolism, I think a lot of times, women in their 50s talk about metabolism like, it's all about my metabolism. It's just so slow. Does metabolism only affect like weight gain and weight loss? And if it's not, what other things is this slower metabolism or metabolism affecting?
So that's a great question. So I don't know what else it is affecting.
Yeah.
I mean, we definitely see that after women go into menopause and lose estrogen, we see a decrease in lean body mass. We know lean body mass is one of the biggest predictor of your metabolism. I think what a lot of my patients misunderstand, or even a lot of other medical colleagues, is that the vast majority of our daily burn is our metabolism. So 60 to 70% of the calories I'm going to burn today is just me sitting around doing nothing, just my body functioning. And about 10% is what they call the thermic effect of food. So it takes energy to break down break down food. And then the rest is physical activity, which is only 20 to 30%. So a lot of my patients say, I'm just not moving enough. They do say the metabolism, but they also say I'm not moving enough. But the metabolism is the biggest part of our daily burn. And the only thing we know that really boosts metabolism is having more lean body mass or more muscle.
Okay.
And so I think that's particularly important for women, as you mentioned, women. Because when we get older in menopause, they lose more muscle mass, and women aren't as comfortable typically with resistance training, right? They've been taught aerobics and cardio, where guys are, want to go throw around weights and resistance. So a lot of the education, I think, for older women should be about the importance of resistance training.
Yeah. We spend a lot of time on that because we see that a lot. And I think women are starting to acknowledge that, like, hey, I'm going through menopause. My doctor's not only, concerned about my muscle mass, but, my bone density and my strength. So I love that that also plays into an individual's metabolism. That's really cool.
Correct, yeah.
When you're looking at someone trying to build this lean body mass, is the only way to do that through resistance training? Because it's a percentage, I was thinking about, is there, could they just diet and then this diet burns only fat somehow and then their percentage is better because it's percent based versus total amount? Or do they have to weight train?
That's a great question. So I don't know of any diet that specifically only burns fat. Everyone that loses weight is going to lose some muscle. Sure. And part of the reason we lose muscle is because we don't need it, right? So if you weigh 30 pounds less, your body doesn't need, the extra muscles in the legs to get you out of your chair, out of bed every morning, because you're picking up 30 less pounds with you.
Sure.
So almost everyone loses some. And the only way I know to build it is resistance training and proper nutrition. I mean, if you resistance train and you don't have any protein or you're malnourished, you're not gonna get stronger.
Sure.
Definitely.
Yeah, and I also know there's a lot of programs that are like, well, I'm not going to work out in the beginning. I'm just going to do this diet and drop 50 pounds in a month, and then I'll start weight training. And there's no way that, I'm not a professional, understanding these different percentages, but in my brain, I feel like there's no way that you can't lose muscle mass doing that. Because number one, again, I don't know of any diet that only burns fat. But number two, if you were working out previously, there's so much less stress on the muscle system that it's like, why would the body use all that energy to keep all that metabolic tissue called muscle? So we see that a lot. Like, I'm going to get in shape and then I'm going to see a trainer. And I'm like, I know I don't specialize in that, but I don't know if that really makes sense.
Yeah, no, we never tell patients if they're in an exercise program when they start with us, we never tell them to stop or scale back. Keep it going. Now, if someone has never exercised before and they come into us day number one and they're going to make a dramatic dietary change, we tell them, all right, wait a couple weeks to get this dietary change down. And then once you get that down, start adding in the next thing. Because we don't want to cut their intake in half and then have them go run, on the treadmill for 2 hours the next day. They're not going to be happy campers.
Horrible.
But we never tell them to stop exercising.
Yeah.
Nice.
We bring up a good point with hey, let's start with one thing, and then we can progress into some other things.
Right.
So Dr. Auriemma, there's, a lot of kind of diet fads and crazes out there and whatnot. And one thing that's gained a lot of press and attention as of recent is the ketogenic diet. And specifically, people seem to really like it for losing weight, for performance, for cognitive performance. But Is that something that you incorporate into your practice at all? And if so, how and kind of what's the responses that you see?
That's a great question, and it is really relevant now. It's become more and more popular. So a little background on the ketogenic diet. So the ketogenic diet is nothing new. It's been around for thousands of years, back to the ancient Greeks. We actually used it in Western medicine, or started using it in the 1920s for prevention of epilepsy in children, so for seizure control in children. So this is nothing new, and it's the same thing as the Atkins diet.
Okay.
Which even when Dr. Atkins started doing it wasn't new. He read an article in JAMA that explained it, so he didn't come up with it. So we keep renaming it, and kind of keeps coming back as a different name every few decades. So our patients can do a ketogenic diet if they would like. We don't have a one-size-fits-all diet. The key I tell my patients is, if you're going to do a dietary program with us, kind of what we figure out to do is what you have to do for the next 50 years.
Okay, nice.
So if you don't see yourself doing this till you're in your elderly age, and then you can do whatever the heck you want, I tell them, when you're over 80, go do whatever you want. Start smoking, drinking, drive without your seatbelt. It's
there
fine.
You go.
But if you want to stay healthy until then, if this diet works for you to help you feel healthy and lose weight, then that's probably what you have to keep up doing lifelong. So the idea of I'm going to do this for 3 months or 6 months and then go back to eating the way I did before, it's kind of pointless. I tell patients, don't even waste their time.
Right.
But if they want to use a ketogenic diet, that's great. We see terrific improvements in things like type 2 diabetes.
Awesome.
We see remission of type 2 diabetes.
Wow.
So patients even on insulin that can come off insulin.
Wow, that's awesome.
I had a lady who was on a pump, an insulin pump, and was on a pump for I think almost 10 years. She came off of it and now has diabetes controlled with just oral medications. But you have to be willing to buy into that lifestyle long term.
Yeah.
And for patients that enjoy eating those types of foods, there's nothing wrong with that.
Sure. Is there ever a concern, one objection that I've heard, or one, not objection, but a concern that I've heard that's been brought up is, okay, well, what happens to the person's cholesterol levels? Like, is there ever a concern with that? Or do you see fluctuations in people's cholesterol levels that would indicate that maybe this isn't the thing to be doing? Or are cholesterol levels really not even the thing to be worrying about?
That's a great question. So that could be a whole podcast.
Sure, yeah.
And I don't know if I'm the super expert on it, but I can tell you what I know about it. So I think we give cholesterol a little more credence than it's warranted, especially under our current lipid profile panels that we look at. So when we look at our cholesterol numbers, we're looking at what we call volume of cholesterol. So, how much cholesterol would fill up a room, when in actuality, what probably is a better indicator or a better prognosticator of heart disease is the number of particles in that cholesterol.
Okay.
So if you have, say your bad cholesterol number, your LDL is 100, and it takes 10 particles to make up that 100. So you have 10 big pieces of cholesterol versus 100 pieces to make up that same cholesterol number. If you got the big fluffy ones, it's actually safer for you. It's less of a heart risk. So that number that we typically get when we go see the doctor is not necessarily the best number for indication of cardiovascular disease.
Okay.
And how that comes into play with the ketogenic diet is when we do ketogenic diets with our patients, we see about half of them, their cholesterol goes up.
Okay.
The other half, their cholesterol actually goes down,
Wow.
which is completely counterintuitive.
Yeah.
They're eating eggs and bacon and having the grizzle on their steak, and they're doing well. And something about the ketogenic diet, a well-done ketogenic diet should also have some vegetables too.
Nice.
So you have to have some in there. And so about half go up, half go down. But even in the ones where the cholesterol goes up, when we do more advanced lipid testing to look at these particle numbers or particle sizes, almost universally, in most cases, it's in the favor of the patient. So even though your total cholesterol number went up, there's actually less particles that make up that cholesterol. So your actual risk for heart disease did not go up.
Oh, that's very interesting. So if one of our listeners is thinking, okay, well, I'm doing the ketogenic diet, or I've done keto in the past, and they go and get their blood work done, kind of what numbers, because they'll get their LDL, they'll get their HDL, they'll get their total cholesterol. Which of those, or is it a different reading, tells the total particles? So
that's a different reading. It's a more advanced testing. So most physicians to date don't order that routinely. You have to ask for it. And to be honest, probably half of the physicians out there, I don't think probably understand it. This is more of emerging science. So you'd have to find someone that understands it, or a lipidologist. So if you were on a ketogenic diet and numbers went in the wrong direction and people were concerned, I would definitely ask for the advanced testing and maybe go see a lipidologist or someone who specializes in that.
Gotcha.
And a big key with the ketogenic diet is you don't want to check your cholesterol right away.
Sure.
So you got to let your body get adapted to the diet. So if you do a ketogenic diet and check your blood work in 2 or 3 weeks, it's going to look terrible.
Sure.
You got to give it a few months so your body adapts so it starts burning those fats and using that cholesterol for energy.
Gotcha. What are some of the biggest challenges that you find the patients may run into when transitioning onto a ketogenic diet?
Well, one of the difficulties with starting a ketogenic diet is patients experience what they call keto flu. So you feel kind of crummy at first. You can feel headachy, you can feel weak, sometimes even have trouble concentrating the first few days as your body adapts. There's some things we can do to help with that. One is to drink plenty of fluids, specifically fluids with salt in it. So even doing like a bouillon cube or two.
Okay.
And as your body adapts, usually it's pretty quick. That keto flu is only a couple days. Once you get past that, patients feel pretty good.
Awesome.
And we typically see energy levels go up. As you mentioned earlier, some people are using this to enhance cognition. It's a big thing in Silicon Valley. If people are doing either a ketogenic diet or intermittent fasting to cause ketosis because they feel it gives them an edge in terms of their intellectual abilities.
Sure.
So there's a lot of benefits that you'll see over time. But the first few days can be tough.
Yeah, I bet. Now, on that note, with the intermittent fasting, when patients come in, you're talking to them about their nutrition and the kind of timing of their nutrients. Do you ever promote an intermittent fasting eating protocol, or do you have them eat more frequently throughout the day? I remember kind of in the early to mid 2000s, it was, at least that's why I became aware of it. The idea was you want to eat, every 2 or 3 hours to keep your metabolism revved up. And then I've heard, different people saying, well, maybe that's actually not what you want to do. So kind of what, from a timing perspective, do you recommend for many patients?
Whatever the patient's willing to do.
I like it. All right, that works.
So that's a great question, though. Yeah, because I was exactly the same school of thought. I was trained that, hey, you have to eat every fefew hours, and we do. We have some patients that every 2 to 3 hours they eat on a schedule, but the key is that they're scheduling their eating. So they're being mindful, they're paying attention to it. So if that works with patients, they like that every 2 to 3 hours. They don't want to feel any of that hunger. That's fine. Other patients love the intermittent fasting because they don't have to worry about eating for hours. They can get through that period of hunger. And a lot of times it kind of gives them a sense of control. Hey, I was hungry.
Sure.
I got through it in 20 minutes. I drank some water, waited, the hunger pains went away. I got control of this, and they love that feeling. Other people don't like to feel that hunger. So it's whatever the patient's willing to do.
Okay, awesome. Yeah. Now, does your clinic have anybody that specializes in sleep management or, helping the people or helping the patients if they're not sleeping well or anything like that? Because I'm guessing that would really disrupt, their hormones and the weight loss efforts.
Yeah, so that's a big part of, successful weight loss is you have to be getting proper amount of sleep. And I think that's something as a society that we haven't done well in. If you look over the last 30 years, we're sleeping less than we used to. We have more interrupted sleep. We do a questionnaire when patients come in. We'll offer a home sleep study if we think they're at risk for having sleep apnea.
Okay.
And then being part of AMITA Health system, we have a number of specialists. We have a sleep center.
Gotcha.
We have sleep doctors that I can refer to. So if we identify an issue with someone, we can send them there.
Sure.
So
now, Dr. Auriemma, what have you seen as far as results from surgical interventions for weight loss? Is that something that you've seen be effective long-term? Is that something that has not really held up? It creates short-term weight loss, but because we're not actually changing the metabolism, then the weight comes back. What's been your experience with that?
So the truth is the single most effective intervention we have today for treatment of obesity is weight loss surgery.
Interesting.
Yeah. So if you look at all the studies, you get the best outcomes long-term with bariatric surgery.
Interesting.
And we don't even like to call it bariatric surgery anymore. We like to call it metabolic surgery because now we understand that it changes a lot more than just making a small stomach so you can't eat a lot. It actually changes some of those gut hormones that I was talking about before. So some of those hormones from the stomach like ghrelin, which causes us to want to eat more, it actually drops with these weight loss surgeries. So it's much more than just creating a small pocket or changing behavior. It actually changes us physiologically.
Interesting.
Now, is it we do surgery and then you're fixed when you wake up? No, this is just one of the many tools that we can use to help with weight loss. And patients can still regain weight even after bariatric surgery. Okay. But if they combine that with a good behavioral program and support, patients do really well. Historically, bariatric surgery got a bad rap, 20, 30 years ago, especially when I was in early training. because the risks were higher, but now it's done laparoscopically. It's much safer. It's on the safety level of gallbladder surgery, which is the most common surgery that's performed in the United States. And the surgeon's mentality in the past, long time ago when it first started for many of them, was you get the surgery and you're fixed. And like most surgeries, right? You go in there, you take out the appendix, you're fixed.
Right.
You don't need lifelong follow-up for an appendectomy. You're done. These patients need lifetime follow-up even after surgery. And so letting patients understand that and having a medical system built around that to support surgical programs that do that are very important. And that's what we do at AMITA.
Okay.
So we have a very strong surgical program that's been around for many years. I think it's like 30 years.
Wow.
And we're one of the pieces of the puzzle to help those patients after surgery.
So you called the bariatric surgery metabolic surgery. And does that actually mean that their metabolism changes, or is it just a name that you guys have named it because it helps people, lose all this weight?
So when we look at the gut hormones, particularly a hormone called ghrelin, which comes from cells in the stomach that causes us to want to eat, increases hunger, those levels actually change with surgery.
Wow.
So it does have metabolic effects that alter the ability of the body to control weight. And so, that's why we like to call it metabolic and bariatric surgery or metabolic surgery. And we even see, type 2 diabetes go into remission with surgery. And you don't see these things necessarily go into remission like after they lose 100 pounds.
Sure.
They'll walk out of the hospital without insulin. After 2 or 3 days. You'll walk in the hospital on insulin 4 times a day and then walk out 2 days later with no insulin. So it's not just the effect of losing 100 pounds, because you didn't lose 100 pounds in 2 days with surgery.
Sure.
It's the changes that these surgeries bring about in terms of our metabolism and metabolic pathways.
Wow.
So it is a really cool indicator of showing how it really isn't. I mean, it is weight, but there's other big factors. If you can have huge changes just in a couple days from having this surgery.
Correct,
It's really cool. Correct. So I don't know if any of our listeners also binge on the TLC show, My 600-Pound Life, like I occasionally do. But you know how they make the participants lose weight before they do the surgery to show that they're going to have the willpower after the weight loss surgery? Do you guys have people do that as well?
So I don't watch 600-Pound Life. I think I've seen bits and pieces of it in a hotel room. I don't have cable.
Oh, nice.
I have antenna service.
It's a good call.
Yeah, I never went to bed at night saying, I wish I would have watched more television tonight.
Right, exactly.
It never happened to me.
Yeah,
So I got rid of cable about 8 years ago. It was
Smart.
great. So I haven't watched too much of the show, but I understand the sentiment that, there's this feeling that we need to have patients prove their willingness. But I've never had an endocrinologist tell their type 2 diabetic, well, until you stop eating sugar, I'm not going to give you your insulin. You gotta show me you're not going to eat sugar, then I'll give you. Or I never had a cardiologist tell a heart patient, well, until you start exercising, I'm not going to do your bypass because you're just going to ruin my coronary bypass, and we're going to have to do another one in 10 years. So just die now. So why do we treat this disease so differently? And I think this goes to the bias and stigma surrounding the disease of obesity, in that it's a character flaw, it's weak-willed people, it's just calories in, calories out, so you can fix it, right? You got a calculator, you can fix it, without really understanding the physiology behind it. And I sometimes like in this, this example of the physiology and these hormones that drive behavior. These hormones cause hunger, these hormones affect metabolism. And it's like telling my patient who's a female, like, all right, go home tonight and just don't ovulate. Right? Don't ovulate for the next month. It's a hormonally driven process. Similarly, many of our behaviors, sleep, eating, a lot of those things are all hormonally driven. So we have to really understand it as a disease process. So now sometimes we require pre-surgical weight loss because you cannot physically do the surgery, or the surgery might be too much of a risk. But this idea that you have to prove it to us that you're going to make changes, we got to move away from that.
I gotcha.
So we'll keep that for the drama of television. It's not real.
I'm not sure why they do it on there. Maybe they, sometimes I do have patients that have had to lose weight before surgery because they were just too big for the surgery.
Sure.
And it wouldn't be safe.
I gotcha.
So that does happen, but we don't make patients have to earn surgery or earn pharmacotherapy or earn my assistance.
Dr. Auriemma, if one of our listeners is hearing this right now and they're thinking, okay, maybe they don't feel like they need to be in a total weight loss program, but they definitely have, some weight to lose. What are some things that you would recommend that they start implementing kind of on their own in order to help kickstart that weight loss process?
Well, I think the easiest thing for the average patient is the average person is probably taking in way too many refined carbohydrates and sugars. So one area most people can start with is trying to cut out sugars and a lot of the carbohydrates. And that wouldn't be like the whole 30. That'd be like the whole 365. So I always tell patients, they come in, they tell me they did the whole 30. I said, what happened the other 335 days?
Right, exactly.
Because, we go to these places like Starbucks, and I see this all the time with my patients. They tell me what they're getting at Starbucks in the morning, and I'm sorry for anyone who has Starbucks stock, but Starbucks is a candy store for adults. It's been sold as a coffee shop, and it's hip and chic, but it is literally a candy store for adults. So you get people money, they have jobs, you send them to the candy store, it's like we're kids, what are you going to buy? And I pull up these drinks out of my patients that they're drinking, and I pull up a Snickers bar next to it, and I said, rather you have a Snickers bar, it's actually healthier for you than what many of these patients are getting in Starbucks and those things. So one thing is get rid of all those simple sugars, cut back on the carbs, and then get moving. And not everyone likes the idea of exercise, so it doesn't have to be exercise. I tell patients, just get a step counter and just try to get more steps. Start there. It doesn't have to be start with a boot camp, Biggest Loser type thing with Jillian yelling in your ear. Just get moving.
Awesome. That's fantastic.
So
Dr. Auriemma, you've talked a lot about kind of what our listeners can do to help improve their health, how you help other people improve their health. But I'm curious, what do you do on a regular basis to kind of improve and maintain your own health?
So I follow a lot of the same advice I give my patients.
Awesome.
So I typically avoid those sugars and refined carbs. I exercise regularly. I make sure I'm getting sleep. I track my sleep. And I don't do the catch-up game. The catch-up game doesn't really work. You can't, not sleep for 4 days in a row and say I'm going to get 12 hours on Saturday and make up for it. So I really protect a 7 to 8 hour block of time for sleep. That's really important. And then, I think balance with, work and family is really important.
Wonderful. That's fantastic. Now, if any of our listeners are sitting there thinking, you know what, I really need to get in touch with Dr. Auriemma, I need to get in touch with his staff, go to his clinic, how can people find out more about you? How can people connect with you?
So if they'd like to connect with myself or our program, they can Google AMITA Weight Loss Solutions. And I'm sure our website will come up there. We have 7 locations in the Chicagoland area.
Fantastic.
And we have a big team of individuals committed to helping our patients be successful long term.
I love it. I love it. Well, Dr. Auriemma, the question that we always like to wrap up with for all of our guests is, what is your definition of health?
My definition of health would be able to participate in the activities in life, whether it be work or play, unencumbered by either physical or mental, emotional ailments.
Beautiful. I love that. Yeah, that's great. That definitely, again, vibes with what we're trying to help people do here is kind of promote this physical freedom, as we'll call it, and help people continue to do all the things in life that bring them joy for as long as they want to do them. So right on, we're definitely in line with that.
Yeah. I think a lot of people always feel like, when I get healthy, everything's going to be perfect and I'm going to get my body so there's zero pain and zero extra fat and I'm eating perfectly. But I think that kind of always misses the point. And I think the point is, again, what you said is doing the things you want to do and feeling like you can participate in the stuff you enjoy.
Correct.
So I love your definition, and our listeners are like, all right, Julie and Charlie say that all the time. So,
and that may change over time, right? Because what we can do when we're 20 versus what we can do when we're 80 may be different.
True.
Right.
True.
Absolutely.
Yeah. Well, Dr. Auriemma, thank you so much for joining us. We really appreciate your time. We really appreciate you sharing your expertise with us. I mean, the science behind fat loss and weight loss is just fascinating. So it's much more in depth than what is typically portrayed in the media, in magazines, online, and it's really important for people to understand that, like we said a lot during this podcast, it's not just calories in, calories out. There's so much more that goes into that. So thank you for sharing all that with us.
Well, thank you for having me today.
Absolutely. Now, for our listeners, who do you know that needs to hear this episode? Who do you know that needs to connect with Dr. Auriemma and his staff? Share this episode with them so they can learn more about the amazing work that he and his staff are doing. And while you're online, if you wouldn't mind, head on over to iTunes and leave us a rating and review. We always appreciate it because it helps other people who are looking for exercise information, who are looking for health information, who are looking for weight loss information, find us easier. So if you found value in today's show, please leave us that rating and review. It means the world to us. Well, thanks so much for tuning in. We always appreciate it. Have a fantastic week, and we'll talk with you all next week.